Um, this lady is going to undergo a distal radial fracture fixation. We are going to do an infraclavicular block. I'm going to use a linear probe and I'm going to inject the 3 cords separately so that it can kick in faster. I don't want failures demonstrating to you guys, then I go back home with bad memories. When I saw Dr. Shaker's block work within 5 minutes, this will take about 15 minutes still, but I want it to work. And instead of doing the pre-procedural scan, I'm going to do the scan after having prepped the skin. And I'm going to cover my probe with a tegaderm. And they're going to get me a tegaderm. And then I'm just going to put the corners with a towel. The central hole towels in my country is expensive. Already, I notice I'm spending about 100 times more than what these guys are putting in the blocks. So I'm going to learn something from them before I go back, how to make it economical for the whole wide world. Okay, I'm going to I already did the pre-procedural scan while she was waiting in the waiting area. And I know her posterior cord is approximately 4.5 centimeters deep. And so I'm going to take a 50 millimeter needle. And I make sure I don't cover her tight so that she doesn't feel claustrophobic. I will expose the shoulder joint because that's where I start my scanning process. Where is the tegaderm? Yeah, thank you. The lady has received a cc of fentanyl and a cc of midazolam for sedation. Oh, no. Yeah, please, sorry. And somebody was asking a question about why you want, this is sterile still, so if you want to use for somebody else, okay. I'm going to follow the same principles of the local principle. I'm mixing ropivacaine with lidocaine 2%. I have made up 40 cc's. My intention is to give 10 cc's near each cord. I will infiltrate the skin with the same mixture. And I've got a little buffer in case some of mine leaks out, or if I want to supplement somewhere with a needle movement, I have enough in my syringe. Okay, so, and the gel, can I have a little bit of gel? I want a sterile gel. Yeah, I've got the lignocaine here. Yeah, I've got the local there. Yeah, I've got it here. Yeah. And I usually have the notch facing cephalad, and it's going to be parasagittal position of the probe. Okay, I'm going to start off on the shoulder joint, then identify my way through. Thank you, lots, there we go. So let me start on the shoulder joint. So when I put my probe, can you increase the gain on this one, please? And lean the screen towards me a little bit so that see, okay. Looking at the shoulder joint with the bicipital groove, head of the humerus and the biceps tendon is there, and supraspinatus tendon is there. And I'm going to move the probe medially, maintaining the parasagittal orientation. And I see the next mountain, which is the coracoid process. Then I'll drop my probe in the valley, where I hope to see the axillary vessels. Okay, so I'm looking for the axillary artery. That's the infraclavicular first part of axillary artery, and you can see the pulsatile structure there. And I'm going to rotate my probe ever so slightly. Now I can see the medial cord between the vein, which is lower down. At about 1 o'clock position to the artery is the medial cord. Posterior cord is somewhere around between 5 o'clock and 6 o'clock. And the lateral cord in this position is not seen well. It is somewhere where the arrow is pointing to. So what I'm going to do, I'm not going to use the nerve stimulator because she's got the fracture. So bring down there we go. Can you increase the TGC at the bottom? So I'm adjusting what is called the time gain compensation to see the posterior cord a bit better. Now I can see the posterior cord a little. Lateral cord and posterior cord are very close to each other in this patient. So I'm going to, from the lateral side, superior side of the probe, I'm going to infiltrate under ultrasound guidance, okay? So I'll put artery right in the middle, and I'm ஒரு சின்ன ஊசிமா கொஞ்சம் வலிக்கும். See, I'm all the way down to the pectoralis muscle, so I'll come back out infiltrating. It is the same track I'm going to use for my other needle, the 50 millimeter needle. And the 20 cc connect பண்ணிடுங்க. And the nerve stimulator working. We don't have a nerve stimulator. If you want, in case. Okay. Point 6 போட்ட போறோம். And the 20 cc hook up பண்ணுங்க, flush பண்ணிடுங்க. There we go, good. Yeah, that's good. 6 and 9. So I'm going to go towards the 6 o'clock position of the artery, and they have put the beam steer so that the angle of insunation will be perpendicular to my needle. Okay, I like that position. I can see the artery, I can see the posterior cord, I can see the medial cord. I'm not sure about the lateral cord. Vertically down. இன்னொரு சின்ன ஊசிமா உங்களுக்கு வலிச்சாலும் வலி நல்லா வச்சு. I'm not ergonomic. My machine should have been across. Oh, there. Okay. Okay, I did. Can you see my needle coming?
Yes, ma'am.
Okay. My aim is to go underneath the artery. I still haven't hurt her so far, and she's a very nice patient and nice and skinny. My aim is to go underneath the artery. Now I may change the direction a little bit. Okay, I got a twitch, and I think that is the posterior cord twitch. I feel it in the back of her arm. Can you aspirate and inject 1 cc? No blood.
Injecting. 1 cc injected.
Okay. And you see the dispersion of the drug underneath the artery? Okay, aspirate. There we go. The artery is getting lifted. Okay. I'm going to inject about 10 cc's there. And the posterior cord is getting hyper-echoic now, just at the bottom of my injectate. Okay. Okay, you can inject 15 cc's there. 15. Yeah, okay. I'm injecting 15 cc's underneath the artery. Okay, that's good. Okay. Now I'm going to come back out. That's good. Okay, I'm going to come back out a little bit till I can position my needle at about as 1 cc for me. The art. One more cc there. Okay, inject 10 cc's there. Now you can drug spreading superficial to the artery too, surrounding the artery completely. And I have injected a total of okay. Technically, this should be enough for her. But for the sake of completion, I'm going to show you how I attack my medial cord, which is seen there. Okay, I'm going to come back out. And I'm going to make my needle pretty flat. It's almost like an in-plane insertion. My hand. See, tip is, there we go.
Yes.
Okay, can you inject 10 cc's there total? Aspirate with each 5 cc's, after each 5 cc's. That's my medial cord getting surrounded. So hold on for a second, I want to go past that nerve. Can you inject 1 cc? Aspirate and inject 1 cc.
Injecting 1 cc.
Okay. Okay, another. You can deliver another 3 cc's. That should be enough. So that's all I'm going to inject. That's plenty. Plenty. Good. You can stop it. So I injected the posterior cord with about 15 cc's, the lateral cord with about 10 cc's. That's 25. Another. How many cc's did we inject for the medial cord? 10. So we have injected about 15, 10, 25, 35. 35 cc's of local anesthetic. Quite often when I have delivered so much drug posterior to the artery near the posterior cord, my intercostal brachial kicks in. And some of them don't require. It's about 60-70% that I will get the intercostal brachial. So, thank you.
Thank you, ma'am.
Thank you.
Any questions? Madam?